So, cool. We are now recording. Welcome to class and all of its fun and glory. Today we are going to dig into the hip. Hips are tremendously fun and exciting things and extremely stressful to deal with. So one of the reasons that we began with the knee was because for the most part, I can take my hands and touch just about any structure that I need to. I can't really quite get to the ACL, but I mean, MCL is very palpable. LCL feels really cool. When we start getting to the hip, then all of that flip-flops and changes. There's so many layers, so many intricate little pieces. And so organizing it is an inherent necessity of life. And so it still follows the same exact pattern that I would like you to focus on for the other pieces. So let me say that. Oh, that's absolutely not what I wanted. All right. So we had this little document called Lower Skeleton Landmarks. And within that document, we had knee, below the knee, and above the knee. And you should have taken a fun little quiz on that recently. So, lovely screen. So, below the knee, we've done above the knee is where we are now. So, there are a tremendous number of little nooks, crannies, and components throughout. And what we need to do is be able to find that. So we should have full screen shared. Yep. So on one side, you've got above the knee, some of our landmarks that we need to care about and worry about. And on the other side, you've got visible body, correct? Good. Yes, you can see visible body. Awesome.
Yes.
Good stuff. Thank you. So pelvis, the main component that we're looking at that is simply to say hip is to say pelvis interaction with femur. So that's kind of your first component that we want to identify. But pelvis itself becomes a bit more complex than that. If I touch it, even in visible body, it's geared to treat it as separate bones because it's actually three fused bones together. No? Oh, you did funkiness there. Okay, so you've got your ilium, your ischium, and your pubis bones. So iliac crest, iliac wing is this big kind of outlying anchor point when we have these massive spaces. It is all anchor points for muscles. And then we have your pubis, which is sitting up in front. And then down below, we have your ischium. So main places that we have spoken about before have been anterior superior iliac spine, anterior inferior iliac spine. Both of those are important to us because they are attachment points for muscles that act on the femur or at the knee below that. We've also discussed ischial tuberosity down here, and that ischial tuberosity is again something that was relevant to us at the knee. So the rest of these landmarks we haven't played with too terribly much or at all, and that's because they are more specific to hip per se, or up into pelvis. So I'm going to excise a little bit of stuff. So we're going to get rid of the linea alba so that we can kind of get a better view of the pelvis. There's two separate, well, we'll stick to hip first. We'll come back to pelvis a little bit. So hip itself is the articulation of the femur, the femoral head in the acetabulum. The ligaments for this really aren't that tricky. It's kind of, we've discussed how ligaments are reinforcements of the joint capsule in a lot of different cases. And that's really kind of what we're looking at here. So the directional bandings of these ligaments for the hip are really just kind of directional lines of pull that the hip is going to restrict against. And I'm not going to care too much about those. They're named by their connection points. So let's go ahead and dig some stuff out real quick, and then I'll come back to it to explain why. So if I look into the acetabulum, if I look into the hip socket, you have this lovely rim of cartilage called your articular cartilage, the acetabulum. It is, and then the labrum itself. So the labrum is designed to be a kind of an extension outside the rim. So it goes beyond the length of the bone. Here in the hip, there's going to be injuries tied to it. You can have labral tears. We will discuss those labral tears, but it's not nearly as pronounced of a conversation as, say, when we get to the shoulder. The hip, this bony socket, it's fairly deep. There's quite a bit of space in there for the head of that femur to lock into. So the acetabular labrum extends a little bit out, but what it's doing is kind of creating a cushioned endpoint when the femur and the femoral head pushes up against it rather than a bony block. So it deepens the socket a little bit, but it also has a little bit of give to it when we push those end ranges of motion. If I go inside and touch, just like I said before, where we have, if I touch any given one of the bones that make up the pelvis, it's going to only highlight the subcomponent that's been fused in there. We get the same view. And so what you're actually going to see is this is kind of almost by thirds the junction of all three of those bones together. So the ligaments become super simple when I back out again and give myself my skeletal system back. Ooh, there we go. It's just going to be the name of those bones that they're connecting. I mean, much like we had anterior talofibular or tibiofibular ligaments, we're getting the same exact thing. We have iliofemoral ligament from the ilium, which is your big iliac crest, to the femur, the femoral. If I come forward, I'm going to get pubofemoral. If I roll it around to the back, then I'll get ischiofemoral. So super simple, not rocket science, not meant to be tricky or hard. Those three all kind of bang together and overlap together to create our joint capsule. So this document here is the one that I have put up online. So it actually outlines you've had a range of motion document posted online forever. So I just cut and paste out the sections of ranges that we need to have. We have how many degrees of freedom with the hip? It's cool. I'll wait. How many degrees of freedom? Somebody be brave. Say it louder.
3.
Yeah, who was that?
Diana.
Awesome. Hey, Diana. Good job. There's 3 degrees, right? So our degrees are defined by a movement within a plane, and we can hit all 3 planes. We have flexion, extension, abduction, adduction, and then internal, external rotation. So all of those are very much in front of us here. So I think the goal at this point is to kind of work our way through the muscles that create each of those motions. So we'll group them all together to kind of get a feel for it. So there's quite a bit going on here. So let us kind of work through that, and I think I'll pause once we get through the muscles, because that'll be enough to abuse you with for the sake of a day. And then when we come back on Wednesday, you'll ideally have worked to get those lodged in your head so we can move on to next pieces. This piece is going to feel like it has some of the most detail. But again, I think grouping these things together is quite simple. So hang tight 1 second. I'm going to pause me because I'm a snotty little kid. Yeah, all better. So good times were had by all. Where do you want to start? How about I don't know, where do you want to start? Let's pick one and do it. Let's do hip extension. Let's do hip flexion. I like hip flexion. How's that? Good place to start? Great place to start. I'm going to maximize this, I believe. Display full screen. Yes. Everybody see it? This and only this? I hope so, because you're not talking to me. So, hip flexion. I'm going to cut out some stuff so we don't have to see quite so much noise. And again, we'll come back to all these fun, happy pieces later. And what we're left with are, well, let's kind of work our ways through it. So, what else can I get rid of in this view? So we're going to look at this right leg here, this side right there. If I want to just get down to hip motion, what other pieces can I get rid of?
Sir, would you want to remove the quads?
Oh, do it. Well, some of them. So which muscle in particular? What muscle should I get rid of?
Okay,
Name one.
I would say keep the rectus femoris involved because that I believe reaches all the way to the hip, so that'd be part of the argument.
Brilliant.
But I would say cut out maybe the rest to them because I believe they have origins just a bit inferior to be part of the argument.
Awesome. So somebody give me some names. He's not wrong. So all you got to do is be right about what muscles are quad muscles.
Vastus lateralis.
Oh, there it is. Vastus lateralis. Boom, it's gone. And it went there anyways. What else?
Vastus medialis.
Oh, vastus medialis. Give me another one.
Vastus intermedius.
Oh, and it's hiding underneath. So it's gone. Now it's gone. Okay, cool. So you start simplifying it when you dig through and kind of piece together, focusing only on the components that we really want to play with. So, I can't talk to you now, right now, friend. Okay. Rectus femoris, first one that Ben had mentioned, that we have discussed already, and it is very much a hip flexor. What is its origin?
Anterior superior iliac spine.
Ever so close, sir. Try again.
Inferior.
Inferior, AIIS. So if we come in here, we zoom in, and this right here is the point of your hip. Right there, ASIS is the point of your hip, and you'll see that rectus femoris is attaching just below. So clear the drawing, get rid of that. And if you draw in your thumb, and it's about a thumb width below and a thumb width. Oh, that's an ugly thumb. Gotta work on that. Inside, so a thumb width in medially and a thumb width distal, you're gonna end up finding that AIIS landmark. So, rectus femoris, one of our quadricep muscles, but we've discussed it because it originates above the hip. It acts on the hip as a hip flexor. Now, anything that crosses two joints does a great one or two help us out. It also creates a weak point in the system because those tend to cramp faster. Those tend to present with injury a little quicker. So it has its limitations. You will learn in eval, there are tests to isolate rectus femoris from our other hip flexor muscles. So let's chat about what those other muscles are real quick. I'm going to kick out rectus femoris so we can ignore it for now. And the next pairing we have is a muscle group called your iliopsoas. And I'm pretty sure, yeah, it's going to grab one or the other. So iliopsoas, Let me escape full view so I can type this out for you. Hip, 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 hip flexion, iliopsoas. So lovely name. It's actually a combination of muscles. So that combination is the iliacus and psoas major. Psoas major. So iliacus and psoas major. If there's a superior, there's an inferior. If there's an anterior, there's probably a posterior. If there's a major, there's probably what?
A minor.
A minor. Brilliance. Love it. So there is a minor. So what we're going to see is this is iliacus right here, dropping in and down. It fills up the inside of that iliac crest. I'm going to kick a friend out here so that we can kind of dig in. And you're going to see this landmark right here. So if this is my greater trochanter, this is my lesser trochanter. It's on the inside and it's very much an anchor point for my hip flexor muscles. Again, one of those landmarks that we needed to pick up now that we're working on hips. So iliopsoas, iliacus drops in and psoas major comes down with it. And you'll see they have very different origins. So psoas major is coming off of T12 through L5. So it is stretching along multiple lumbar processes all the way down, all the way up into the base of that sacral spine. And then it flows into that lesser trochanter. Whereas iliacus is solely off that iliac crest, and then it drops in. So psoas major is going to be responsive to spinal motion. So if my lumbar spine isn't anchored well, then it can get injured or it won't be working well, because if my lumbar spine shifts a lot, then having a line of pull for it to do its job isn't going to be solid. So when we get into core stability and we get into pelvic stability, hip flexor strains are very commonly tied to poor core activation. So while the person's injury is healing, you can typically have them focused on core strength, and that problem will resolve much, much faster. So I mentioned psoas minor, and it has this funky little pathway where it's dropping down into the pubis itself. So this would make it a phenomenally weak pelvic tilt muscle, trunk flexor of sorts. And so it is not part of the iliacus pairing. It does its own things. It is quite separate. We need not to worry about it too much right now. So hip flexion, rectus femoris, iliopsoas, which is iliacus, and psoas major. Now, if I come in, you're going to notice that I have this other muscle that comes off of ASIS, goes down over the top of the hip, which makes it very much a hip flexor. And then it wraps around and drops in behind the knee, or anterior surface of the knee, but almost comes in from a posterior angle. So sartorius is a funny little bird. We talk about sartorius in regards to Faber. Because that's flexion, abduction, and external rotation. So I don't really tie sartorius in as a hip flexor muscle. It facilitates that for sure. Don't get me wrong, it does. It also abducts, it also externally rotates. You'll see a test for it. If you seated in your chair, if you take your right heel and place it over your left shin. Now slide your heel up your shin. And to do that, you are externally rotating your femur. You are abducting to keep your heel on your shin. Your knee's going to keep pushing out farther wider, which is abduction. And you are actively flexing your hip. That is the motion that you would use to isolate sartorius function. So it is never wrong to say sartorius is a hip flexor. It just isn't one of those muscles that I slide into that narrative because it's just a facilitatory component of it, and the others are far more directed to help do that specifically. Clear as mud? So given a select all that apply, if sartorius shows up, you can't be counted wrong for including it in that list. Typically not where my focus is going to be because you've got rectus femoris and iliopsoas doing the majority of that work though. So can anybody tell me how I would differentiate rectus femoris from iliopsoas on an eval? Nobody wants to answer me. This is sadness. Rectus femoris versus iliopsoas. How would I differentiate those?
Did you do it by like having your knee in flexion or your knee in extension?
Brilliant, sir. Thank you. Why?
Because when your knee's extended, you're isolating rectus femoris.
Same conversation we had with superior versus inferior. Why don't you flip that around a little bit?
Okay, so the other way around. So, I mean, if the knee's flexed, then you're isolating rectus femoris.
Yep, exactly right. So if I flex my knee, if I bend my knee down, I put more tension into my rectus femoris, which means I will find its involvement sooner. If I want to put slack on rectus femoris by extending my knee, then iliopsoas can be more isolated. So, yep, good job. So anytime I have a two joint muscle, I get to play with those two joints to kind of put tension on one side versus slack throughout. So easy stuff. So that's flexion. We really pretty much had three muscles that we had to stress about, and that's not a big stress at all. So we're gonna hide him out. I'm gonna go ahead and kick sartorius out of the way for now. And then there's our iliopsoas. And then there's our vastus musculature, the rest of our quads, intermedius and lateralis. And you'll notice sitting deep right here is the largest bursa in the body. That's called the iliopsoas bursa. So it sits, if I let that all come back, it sits right underneath the iliopsoas muscle pair, helping keep pressure off of that pubic ramus, so that we don't have aggravation of that muscle underneath rubbing over the bone. So good thing to know. You can have a bursitis here. You can have inflammation there, irritation there. Where I've seen it in pregnancy, hip flexors tend to get pretty tight. And so anytime you have a tight muscle, it's going to add pressure on the bursa. You tend to get increased pain. If you can stretch things out, loosen them up, doing some hip flexor stretches, then that can relieve some significant issues. So good to go. All right, so back to where we were, kick those out. And that gives us this amazing view of doing our adductors, adduction, because we are staring at our groin muscles at this point. And there are 5 muscles that we're going to put into this pairing, into this set. So things that are going to pull our femur in towards the midline. So we're going to work from top to bottom, and then we're going to talk about some details with this area. So first one, highest up is pectineus. And you'll notice that all of our origin points are going to be in and around that obturator foramen. So it's pretty much going to be anchor points on this side, wrapping all the way around, that are then going to come down and act on it. So if you say pubic ramus or ischial ramus, you're probably going to be right. So again, it's not going to be intended to be hugely complicated. If I get rid of the drawings, I give me my muscles back, I go open the book on this, pectineal line, superior ramus of the pubis. If you've got ramus stuck in your head for these adductors, you're going to be in a great place to kind of come up with the right answer. So find your simplification components that help you hold on to where it's coming at, okay, where it's coming from. Okay, so pectineus, kick it out and kick it gone. And from there, the next one down, I'm going to go behind it a little bit because we're going to have three muscles called adductor. Adductor brevis is the most superior. Next one down from that is adductor longus. So brevis comes in high up, longus comes in diagonally. I'm going to kick longus out of the way so we can get a better view of brevis. And then from that gives us our last one, which is conveniently called magnus because it's absolutely huge. That's beautiful. Yeah, show it.
So beside you, it had no arms, and it kind of sticks up.
So I just want to share with everyone, my wife has worked on green screen. That looks like I have a hole in my hand. That's kind of cool. So we've done origami T-Rex. Yep. So the better half is learning a new skill every day. She can now do a T-Rex. Oh, and she makes excellent videos for it. Subscribe to her channel. She's amazing. Cheapy, almost free. So adductor magnus. Now, one thing you'll notice in here is adductor magnus. It's really kind of a crazy, funky little dude here. He grabs in that medial border of the femur all the way down, which is really pretty cool. And then it has this lovely, massive hole straight through the middle of it. So we zoom in on that hole, and we've discussed that hole before. It's a passageway. It's the adductor hiatus. So that adductor hiatus gives us space for blood vessels to pass through. So conveniently, it stays protected on the inside of our leg. It's where the femoral artery crosses in posterior to go into the popliteal space and become the popliteal artery. So we'll get all the scary stuff out of there. So if you were keeping count, that was 4 muscles because we had pectineus, adductor brevis, longus, magnus, which leaves one more, which is the gracilis. So gracilis is another one of those 2 joint muscles. It's the third one that inserts at that pes anserine. So pes anserine, SGT, sartorius, gracilis, semitendinosus. So S for sartorius, G for gracilis, T for semitendinosus. So those 3 hit that that flat space on the medial aspect of your tibia, right down in here. There is, in theory, you'll see it sneaking in right back up in here. There is a bursa that hides in that space for the pes anserine. More often than not, if you're thinking pes anserine bursitis, you really ought to rule out something like a stress fracture first, because that's really pretty far more common, probably. Regardless, gracilis drops way down. It's the most superficial. It is the 5th of them. It's there. I don't think we ever talked about that guy before. I don't think we dug that deep. So there's this tiny little muscle sitting underneath your quadriceps called the articularis genu. So the muscle's job is to grab onto the joint capsule at the knee. So when you extend, it pulls the joint capsule out of the way so it doesn't get pinched inside the joint. Handy. Never seen an injury there. Wouldn't know what to do with it if I did. But that muscle exists. So adductor hiatus, which also gives us kind of that adductor canal. If you take the view of your musculature here, and I cover it back up, let me kick sartorius out of my way, and you're going to see that there is what appears to be a passageway that just kind of flows in between adductor magnus and sandwiched with vastus medialis. So two very strong, broad, powerful muscles that create a groove, a canal, a passageway all the way down to the adductor hiatus. That's called your adductor canal. So it's kind of like your anterior musculature providing a cushioning, a padding, a passageway with your adductors for those blood vessels to go. So, I mean, these are massive vessels. And in the process of kicking out your musculature, again, if you've got any kind of suspected femoral fracture that has every capacity to sever that artery, it makes it a medical emergency. So it is tucked in right close to that bone, and yes, there's musculature behind it and on top of it, but not a lot stopping it from shifting in towards the bone. So any kind of femoral fracture needs to be considered a 911 call. Pull some traction on that thing to help keep those bone shards from sliding around. Your medical response team is going to go put a traction splint on that leg to help hold it and stabilize it so it can't slide around so much. But it's kind of a big deal. So we have done hip flexion, we have done hip adduction, and right now we are in a lovely view to be able to discuss a geometrical figure called the femoral triangle. This is your inguinal canal. Your inguinal ligament, inguinal ligament. If you've heard of an inguinal hernia, we will come back to that. I think we probably referenced that in pathology once upon a time. We have adductor longus, and we have sartorius. So if I was to draw my belt, it would come across my waist right about up in here. If you go just below your belt line, you'll find your pubic symphysis. And in our current situation, nobody's watching you. You're fine. Go find your pubic symphysis. By finding that, and you find your ASIS, connecting those dots gives you inguinal ligament. Sartorius runs diagonally, kind of in an S shape for sartorius. About halfway through that inguinal ligament, aiming down towards your sartorius. If you're nice and relaxed and lay back in your chair, then you can feel your femoral artery. 2 fingers placed in that spot, and you should start feeling the bounding of a pulse for your femoral artery. Cool thing to know. So through this space, we have what we call the femoral navy, which is for the femoral nerve, the femoral artery, and the femoral vein. You can call it the navel if you want, because I can throw in that we have the femoral lymphatic vessels as well. So there's a whole lot that gets passed through that space. That inguinal ligament is kind of a roof line, a covering, a rigid protector so that we can't compress inwards and impinge upon the artery or the nerves or the vein. Kick off some components. However, to do that, to get up into that space where these things run, that's where we start having fascia that has a gap in it. And where that fascia sits and has a hole in it for these other vessels to pass through, if I go and slide in GI tract, you begin to get a feeling for oh, we gotta get that out of the way too. Your small intestines sliding through. There we go. There. Oh, there. There we go. Hey, small intestines aiming down, dropping down through gravity and finding their way to poke through that same little passageway. And that creates your inguinal hernia. So then we have a small gap, and with enough pressure and enough poor pelvic floor stability, then basically your small intestine kind of squeezes through with it to give us that issue. So femoral triangle, quite important because it gives us a landmark reference point to find femoral artery, femoral vein, femoral nerve, all good stuff to know. So what have we done so far? We've done hip flexion, we've done adduction. So let's do extension. Extension's always fun. So extension. First one, we've done quite a bit of them because it's our hamstring muscles. 3 of our 4 extend the hip because they originate at the ischial tuberosity. So those are easy because you've seen them and done them and heard them all. Semimembranosus, semitendinosus. There's adductor magnus. Now, in this view, you see a unique little additional feature. That adductor magnus is actually partially originating on that posterior aspect, on that ischium. So adductor magnus is magnified, is huge, and it does more than just function as an adductor. It is actually, they also consider it to have some of a hamstring component as well because it assists with hip extension. So it's a posterior, in part, a posterior muscle as well that will assist with hip extension as well as adduction. So it's kind of got a dual purpose going on in all of this world too. But for the time being, we're going to kick them out of the way. So at this point then, we have removed our hamstrings, we've moved adductor magnus, we are staring up at ischial tuberosity, and that leaves us our other group of hip extensors, which is our gluteus muscles. Maximus, medius, minimus. Maximus. Good movie. So glute max. Glute max, you'll notice its origin is kind of everywhere. So sacrum, iliac crest, if I hide this out to where I can kick off all those muscles, then its origin is pretty much this entire line. Anywhere and everywhere that it can attach to is gluteus maximus. So posterior iliac crest, and then getting down onto the sacrum and then dropping down. The more entertaining piece, though, is its insertion point. So the proximal third is actually dropping into the IT band. The distal 2/3 drop into the femur itself. So it's got multiple functions in that process. By dropping into the femur, it's directly extending that hip. It's pulling it immediately backwards. We'll come back to it because by dropping into the IT band and dropping down, it's going to create our abduction. So we'll come back to chat more about glute max. So very powerful, very huge. And when we start talking running gait retraining, where I say 2 joint muscles have more fatigue issue. They fatigue out, they cramp sooner, they tend not to produce as much power. That makes them less suitable for power production. Take my hamstrings out of the equation because they're weaker in the process of kind of helping to propel you forward running, and let me target hip extension as my primary propulsion, and you can get more power if you run through your glutes than you can by using an overstride with a hamstring pull. So we're going to kick those glutes out of there, and all of a sudden we start seeing a whole lot of scary. So if we stay looking up high, don't look down low, that gets spooky. So stay looking up high, and you have glute medius. If I bring that back, what I want you to do is on your hip, find ASIS. So in front of your hip on the front piece, find ASIS. If you go about 2 inches posterior, you're tracking along this little piece right in through here. So just about where you get to, it starts raising up. Side of your hip. And just where you start getting to the small of your back, where that pelvic rim has started to rise up, if you drop in and push in deep, it's kind of like a tender spot a little bit of a trigger point in there. It's so you can actually get into a window where you can poke onto glute med, where it's exposed above and lateral to gluteus maximus. If I clear my drawings and get rid of max, then you'll see that that muscle is so much bigger than that though. Like it fills in that entire posterior iliac crest. So the iliacus fills in the anterior side of that, and the glute medius fills in the posterior. It assists with extension by far. It also does a whole lot to help stabilize the head of the femur in the pelvis, and it prevents eccentrically adduction. So by contracting to abduct to pull it out, eccentrically, when I step and land, by firing, it prevents that knee from collapsing in. So where we start talking about patellofemoral pain syndrome, we start talking about IT band friction syndrome. Glute medius is very much a target in our focus on rehab, because its job is very much by doing abduction. So we'll come back to it in just a minute, but by functioning that way, it helps prevent that knee from collapsing inwards. But in this, you can see that it has a direct line of pull to where it can assist with that extension as well. And if you look at your little chart in here, it says action, abduction, and extension of the hip. I wouldn't lie to you. So glute med, we're going to kick it out of the way, and hiding underneath, you've got glute min. Glute min is much more an abductor and less of an external less of an extender. So we'll kind of ignore it for a hot minute, leaving our principal extenders to be 3 of our hamstring muscles. You've got the hamstring portion of your adductor magnus, glute max, glute med. And
So 5 muscles for extension.
6 if you want to add in adductor magnus. Okay, so because we flirted with it, let's go ahead and talk about abduction, pulling this thing out and away. We have 4 principal muscles that are going to do this. 3 of them we've already discussed. So all 3 gluteal muscles are going to assist with abduction. We're staring at glute min, so we'll just chat about glute min. So glute min is going to go. Get off of there. Glute min is going to drop right down and it's just the greater trochanter. And it creates a little bit of a unique issue because if it's getting tight, if it's not happy, we have that greater trochanteric bursa that sits right there. And as you step, that muscle, the banding of that muscle slides back and forth over that greater trochanter, and we can get greater trochanteric bursitis. Quite common. All we need to do is release some of that tension, just like most bursitis. Uh, um, they're going to complain of like a popping sensation when they're about mid stance, transitioning from the anterior to the posterior. They'll feel it pop and click every time, and the more they do it, the more painful it becomes. So glute min, let's add some muscles back in there. Glute max. So glute max again drops down into your IT band. Hiding behind that again is glute medius. So we can see that insertion point. It tucks in right there with glute minimus, just behind it. A little bit less affected by that bursa because glute min's the one that sits right on top of it. Oops. And then there's the one that we keep getting rid of when we start looking at IT band. So where you find ASIS, that first 2 inches past is a muscle called your tensor fascia lata, so TFL. So it's a small band of muscle that does straight abduction, pulling out the posterior pelvic rim. And it flows directly into your IT band. You'll see glute max kind of feeds in with TFL to make up your IT band. And then as we've discussed before, that drops down into Gerdy's tubercle or near Gerdy's tubercle on the tibia. So those 3 together create my abduction. 4 together, sorry. Glute max, medius, minimus, and then TFL. So 4 on that one. It's very weird. It's like my fingers are disappearing. So we've done flexion, we've done extension, we've done adduction and abduction. Let us chat external rotation. So I'm going to exercise out my glutes. And I'm going to chat about 6 new muscles. There are 6 of these. Yay, 6 of these. Who here is, I'm presuming you guys have heard of the rotator cuff, yes? What can you tell me about the rotator cuff? If you say it rotates things, we're going to fight. Where is the rotator cuff? Give me a joint.
Shoulder.
Shoulder, thank you. What's it do?
Internal and external rotation
Of what?
of the humerus.
Good. So the humerus, internal external rotation, the humerus on the glenoid, on the scapula. There's a rotator cuff in your hip as well. So this muscle set that we're about to do with external rotation is very much kind of like the rotator cuff of your hip. We'll get into some functional pieces of the femur, and we really think that the current research and the current approaches to rehabilitation for labral tears in the hip comes from trying to get this set of muscles to engage and stabilize the femoral head inside the acetabulum. So don't think of this as just, hey, that group of really small muscles that I can't remember. It's much more a conversation of these muscles are helping to actively stabilize the femoral head within the acetabulum to provide internal joint stability. So 6 muscles. We're going to go high, we're going to go low, we're going to go up and down, and then in and out. So high, and one of the most important that you'll hear of the most is piriformis. So piriformis, running from my greater sciatic notch and my sacrum over to my greater trochanter. We go low, and you've got quadratus femoris, quadrate muscle. So ischial tuberosity, so it's grabbing down by your hamstrings, and it's grabbing into the intertrochanteric crest, so between my greater and my lesser trochanter. So that was my high, that was my low. And then we go superior gemellus and inferior gemellus. So that's my up and my down. What is Gemini? What is Gemini?
Two identical people.
Twins,
Twins,
right?
right?
Yeah. Superior and inferior gemellus. These are the twins. Good to go? And then we do internal and external. We have obturator internus, and then much more frustrating to find is obturator externus. So these guys kind of come from the inside of the pelvic rim, that's the internus, and the outside of the pelvic rim, the externus. So it helps probably to take a hot second to give me all these muscles back, and I'm going to dig them out again. We're going to hide out everything but. Yep, and yep. And so you can see, get rid of you, and now we're starting to see it. So your obturator foramen is this big hole right through here. Now it's usually covered by a piece of fascial banding, but that right there that we're staring at is your obturator externus. So it's actually an anterior muscle that wraps up and inside to create rotation. So again, so you'll see it popping through right there. Whereas if I get rid of some of these muscles and I look inside of the obturator foramen, so it wraps around that entire hole and then cuts out and around, there's my obturator internus. So either way, you've got piriformis up high, quadratus femoris down low. You've got the twins, superior and inferior gemellus. And then we have that obturator foramen is entirely covered with muscle inside and out. Inside, obturator internus, outside, obturator externus. So those all kind of grab into that greater trochanter, intertrochanteric line to help tuck it up and in to functionally hold it in place through all of our ranges of motion. But first and foremost, they're external rotators. So, easy enough? Yeah, easy enough. Not too terribly bad. Like I said, there's a whole bunch of muscles going on. Now, the hiccup we have in dealing with these things is trying to identify evals on this stuff. I mean, because if anybody's got a problem with piriformis, then you got to be putting your hand all over their butt. And you have to do that in a very complex, professional way. So to deal with that, you really have to kind of get to, if it's getting into any kind of those external rotators, it's deep, it's hard. You've got a lot of different layers to kind of assess through. If you're getting into a hip injury, chronic for stress fracture into the femoral neck, they don't present well. You don't really have a lot of nerves that say, hey, this one spot is where it hurts. It's going to be this diffuse kind of ache and problem and gross. So hips become a little bit daunting because you have to work your way through knowing which muscles are which locations, differentiating between two joint muscles and one joint muscles. It's definitely not the first place I want to throw you into when you're trying to learn this stuff. So hip can be a little bit tricky. Now, last piece, because we've kind of worked our way entirely around the leg, and yet I haven't really discussed internal rotators. So the reason for that is because I'm not going to give you a group of muscles that does that specifically. Anything we do with internal rotation has to do with limb position. If I am externally rotated, then my hamstrings are going to have leverage to pull it back into internal rotation. If I'm internally rotated, so it depends on kind of if it's my hamstrings, my adductors, or my quads or my sartorius that are going to give me leverage to pull it back to a neutral position. So it's a little bit of a pass because I don't need to give you a whole set of new groups of muscles. Just understand that by position, other muscles will pull it back into a more neutral space. Cool? Or from a neutral space, it'll be largely hamstrings that are going to draw it into an internal rotation. So I'm going to guess where I've spoken for almost an hour straight just talking through musculature of the hip, that's probably enough abuse for one day. Tori says yes. So I will have office hours. Let's see. I've got, if anyone wants to hang out, I've got one more class at 5:30. Oh wait, is that what I did? What did I do to myself? Yeah, there we go. I have class about 5:30, so if you guys want to chat, I'm good to chat. If you're tired of listening to me, then that's cool too. This is posted. If you've got other hours you need to, then need to find me, then by all means, we can try to find those some point. Usually evenings are better for me at this point. Advising is going to conflustercate life a little bit for the next 2 weeks because I got to find time to squeeze you happy folks in there. My recommendation is always to go ahead and plan out your life using that Excel sheet. It drives Dr. Sparza nuts. But I personally like to know that all my classes fit in my world. And so, or if I can cut a semester off, then that seems to be like a wise decision as well. So I'm going to stop recording, I think. Yep.
Do you mind reviewing all the